Okay, thank you again. Actually, perfect timing with regards to the case that we're seeing. Challenging. I'll talk here today about therapy of choice for in-stent restenosis with particular focus on debulking agents and atherectomy. Here are my disclosures. So again, kind of take it back down to the basics. We expect to see some episodes of in-stent restenosis after intervention. We tend to see this primarily at the edge with edge restenosis, depending on how we size. That's why I'm a big proponent of IVUS. But you can see that there is some vessel injury controlled when we do intervention, secondary to angioplasty or atherectomy, causing some sort of endothelial dysfunction, as we know. This causes a cascade of inflammation, which happens, and then you can see proliferation of smooth muscle cells, which ultimately can cause this hyperplastic response and ultimately cause stenosis and even obstruction or occlusion. We do see that it's relatively common following femoral popliteal stenting. You can see a variety of studies, but to the screen right, most up to 30% require some sort of reintervention at 1 year. And again, this is a function of either sizing or decision of how you want to treat the particular lesion. I'm going to touch very quickly on DCB. I know there's going to be some talks about that, but you can see here some of these articles looking at DCB versus POBA for in-stent for ISR and the SFA. It's a randomized controlled trial, the FAIR trial, almost 120 patients. ISR had to be over 50% with episodes of chronic limb-threatening ischemia. You can see they were randomized to either DCB or POBA at a length of approximately 10 centimeters, and there's really no difference in the patient demographics you can see there. Let's look at the results, though. For those undergoing DCB intervention versus POBA, statistically significant benefit in decreasing in-stent restenosis following that intervention. You can see here, very, very early on, even up to 1 year, the freedom from TLR was significantly higher with DCB as compared to POBA. And these are a variety of other trials as well that really tend to repeat that or show that type of information. As you can see there, again, the PACUBA trial, the odds ratio of restenosis was 2.8 times higher with POBA compared to DCB. As you can see to the lower part of the screen as well, freedom from TLR for those which was much more beneficial for DCB versus POBA. But I really want to spend some time on debulking. I think straight POBA is not sufficient, so let's see what we can do with consideration for atherectomy. Really, I think the ones that are out there are Jetstream and extramural laser. We'll look at the Jetstream ISR study here. That was previously published, of course. 32 limbs, really zero device interactions, and you can see 6-month freedom from TLR was 86.2% with a patency of 72. And you can see the graph to the screen right as well there, freedom from TLR, again, with the use of Jetstream atherectomy. In the ISR study itself, again, 60 patients. Some of them required bailout stenting, but again, very, very respectable freedom from TLR at 6 months of almost 80% with a 1 year at 60%. Doing that with the use of Ranger, again, which is a multi-center randomized controlled trial with the use of Jetstream with DCB versus PTA and DCB. And this was, again, primarily in the ATK segment, FemPop. The plan was to enroll almost 255, but stopped early due to some issues that we all had 5 years ago, 47 patients. But again, it was nice to look at this. I think it's important. Assigned 2 to 1, and you can see bailout stenting was around 1 in 5, but no distal embolization, no amputation in either group. But benefit, again, for Jetstream with DCB versus PTA alone. Looking at extramural laser, I think most people would tend to prefer this. I would do similarly as what was going on in the live case. That would have been my choice as well, just based on the evaluation for IVUS imaging. Looking at, again, laser atherectomy for treatment of ATK in-stent restenosis. And then you can see it here pleasantly. So a laser atherectomy allows for photoablation and disruption, which helps disrupt cellular debris. Again, this study was 2 to 1 randomization, greater than 50% of the ATK segment. They really had to have at least 4 centimeters. And then this was, ended early due to superior outcomes of laser at 6 months. I mean, a significant reduction of TLR at 6 months, and so the study had to stop at that time. Here, the trial, and you can see similarly as well with extramural laser atherectomy with PTA versus PTA alone, a significant benefit with the use of that. To the screen right again, all primarily statistically significant for primary patency and freedom from TLR, which was important. Also, freedom from major adverse events was beneficial in the laser atherectomy group. as compared to PTA. And so really that is my device of choice whenever possible. You can see here in the trial as well, it all favors to the left side of the graph, again, favoring adjunctive therapy with excimer versus PTA on its own. Let's look at another study here. Laser atherectomy with DCB did show 1 year improved outcomes for FemPop ISR. Again, the retrospective review is DCB with laser versus laser and PTA. Similar situation as well. Again, just data after data here showing you that adjunctive therapy with the laser plus supportive therapy with anti-restenotic therapy from DCB is superior compared to PTA alone. At 2 year follow-up, that was maintained as well. And looking at chronic SFA ISR with laser atherectomy again versus balloon angioplasty, and this was a single center study from Europe. You can see here laser atherectomy with DCB versus DCB alone, and again similarly as well, patency was much higher in the atherectomy with DCB group versus DCB on its own. I mean, at 6 months, 91% versus 60, and at 12 months, double essentially, 2/3 versus essentially 1/3. So we'll show you a quick case. Late 60s, usual gamut of vascular disease, progressive claudication, was stented just under a year previous, had difficulty walking. You can see here again to the screen left. In the mid portion, there is essentially severe in-stent restenosis, practically a small new CTO in the stent, and then the runoff primarily via AT with some reconstitution of the perineal. So then you can see there filling the plantar vessels, and there's good common plantar lateral and medial, cross, IVUS, shows as mixed morphology plaque kind of stuff as we're seeing actually on the live case. And then at that point, plan to either pre-dilate a little bit, and then at that point, consideration for advancement of the laser device across the ISR in an effort to create a channel, follow that ultimately with a, here we ended up using a cutting balloon, and I ended up using a DCB following that, but that's what it looked like at the conclusion, with again, brisk flow, no distal embolization, again, primarily AT runoff, but there's reconstitution of the perineal artery, and then to the level of the, as you can see there, the plantar vessels themselves. So I'll touch a little bit on drug-eluting stents. I think there's an opportunity here for treatment following ISR. Again, this was a study looking at ISR with paclitaxel drug-eluting stents, again, from Europe. 108 patients with 119 those in ISR. You can see there, a third of them had lesions that were really long, over 150 millimeters, and 31% of those were CTOs. Success was essentially 100%. Primary patency at over a year was around 80%. A freedom from TLR was 2 years was around 61% as well. So very respectable results. Sometimes it's a lot of work and you're not sure if you're in a dissection plane or the plaque looks somewhat unusual. Why not consider just relining it with a covered stent or a Viabon? I think, that's also a great idea sometimes because it's difficult to be able to treat all the ISR, and so you're worried about, some residual greater than 30% stenosis. But in those situations, you could cover collaterals, and then they talk about the leg going down hard sometimes. Does put the patient at risk of ALI. However, I do consider it when there's really recalcitrant stenosis. I'm worried that there might be some distal embolization. I'm trying to cage the plaque or the thrombus. If the thrombus, if the plaque, if you will, looked soft on IVUS, so I really depend on my IVUS evaluation. And of course, if it's multiple repeated occlusions and CTOs, I'll just treat that with the covered stent. You can see here, the Reline study showed technical success with Viabon compared to PTA, and of course, at 12-month patency, almost 75% with a covered stent versus PTA, and I think most people would consider doing that. So in conclusion, ISR is very prevalent despite antiplatelet therapy and drug-eluting technology. Advanced treatment, it really gives us very good results from TLR at 60 to 80%. Strong data support use of DCB with atherectomy, and I think most people would not consider just using straight PTA. You'd need some sort of adjunctive treatment with DCB instead of straight POBA, and you can always consider drug-eluting stents or covered stents as necessary. Thank you so much.